Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay. So thank you so much, Akash, for letting me know. Thank you so much, everybody, for joining in tonight. It's been a while. I've not taken classes, and you know the reason. Now we'll be definitely on track, and we'll try to be regular with the classes. Hopefully, we'll be taking up few classes on the practicals to come. So there are a couple of students who've already approached me for the cases to be presented in the class, and I would love to take up the practical classes. They are very close to my heart because I really love to interact with the students, especially when they are presenting and I am the moderator. I love it because I would want them to speak more, and in that way they are able to perform better. So now tonight we have a very important topic, which is sentinel lymph node mapping. But I'll just want to do a little snowballing with you. I would want to know, how much do you know about sentinel lymph nodes? This question is not new to all of you. Okay, this question has been asked several times in your exams, and you've already seen the answers, so you definitely know what sentinel lymph nodes are. But still, I would want to know a little bit from my students. Can you just quickly tell me what exactly are sentinel lymph nodes? I would like to know from my students. So everybody who's there in the class, can you just quickly type it down in the chat box? What is the meaning of sentinel lymph nodes? Trent, yes, come on, students. Let me know what the sentinel. See, lymph nodes, we have a drainage of, you have separate questions on vulval drainage, on cervical drainage, on, endometrial, uterine drainage. But what exactly is the meaning of sentinel nodes? Please tell me that, and then we'll go to the file. Why is it important? With that background, we'll start with this class. It's a very short and crisp class. It's going to be a very sweet and interactive class. So yes, Bratish, I'm expecting an answer from you. So let me know. And please, guys, again, break the barrier. Try to answer. Okay, you can answer it in writing. You can also, let me unmute you and then you can speak. I have no issues. But I would want it to be a very, very interactive session, and I would prefer that you can just type it down. What do you mean by sentinel nodes? For now, that's the question. I'll be asking you more questions. Yes. They're the first, absolutely right. The first group of lymph nodes to which that particular structure is draining, where you are suspecting a carcinoma or there is a carcinoma, and you're taking up a surgery for that. For example, if I've just got to know through a pap smear that this is actually cancerous cells, then I went in and I took biopsy, and it came out to be a squamous cell carcinoma. Then I went in further, dug it deep, and it came out to be a stage 1A1 carcinoma. And now I'm planning to go in for a radical hysterectomy. But before I take up a radical hysterectomy, I'm very skeptical, and I really want to know whether the sentinel lymph nodes are involved or not. Because the moment they are involved, can you tell me what's going to happen? In cervical carcinoma, if the sentinel lymph nodes are involved, then what's going to be the fate of this patient? Would you go in for a radical hysterectomy for this patient or not? You won't. It's very simple. It's very simple and basic maths. In case of cervical carcinoma, the moment the sentinel lymph nodes are involved, you will not go ahead with the radical hysterectomy. You would want to go in for a chemoradio rather than that, right? So in that case, you have saved the patient of morbid procedure like a radical hysterectomy and then going in for a chemoradio, just by knowing in the one shot that there was actually sentinel node involvement, and you don't want to proceed further because there are certain things which are not caught with MRI, PET, or CT scan. Correct? Absolutely. That's one advantage I've given you of doing a sentinel lymph node mapping. So basically what we're trying to do is that we're going to see whether the sentinel lymph node is involved or not. And that's not it. It does not end there. Suppose I inject a dye and that really reaches a sentinel lymph nodes and goes further, and I dissect out the sentinel lymph nodes. What do I do after that? I don't stop there. I have to send it for biopsy. All right, so that's not mapping. Means I'm just mapping it. But sentinel lymph node biopsy means after you've done the mapping, you send it for biopsy, and then it comes out to be positive. And now you're sure that this lymph node group was involved. So that means my lymphodectomy is going to continue from here ahead. Correct? Now, so sentinel lymph node biopsy is actually an alternative to a systemic lymphadenectomy. There was a class that I took on vulval carcinoma. All my students who have my live class recording lectures with them, the ones who've taken mega course package or the ones who've taken my theory course, updated theory course, they please go ahead and see just watch vulval carcinoma, because I've described very important two aspects over there. The idea of lymphadenectomy, the entire process, and the concept of wide excision, incisional biopsy, local excision, and radical excision. Both of them are very important concepts. You will not get it anywhere, and very, very basic concepts specifically for vulval carcinoma. And vulval carcinoma I'm going to be talking about here as well, sentinel lymph biopsy, because that's where it started from. So SLN is actually an alternative to systemic lymphadenectomy in the surgical staging of obviously malignancies, and it's basically recommended in the management of vulval cancer, but now it's also being used in carcinoma cervix and carcinoma uterus. So you have the concept of SLN biopsy or staging. Why? Because earlier what you used to do, we did not have any such thing like mapping and stuff like that, and we would like to just take out all the close by lymph nodes and send for biopsy. And you know what was happening specifically with patients with cervical carcinoma? You did a radical hysterectomy. You still do that. You do over that, don't you? And you're doing a hysterectomy. You took out the lymph nodes. You must have assisted many oncosurgeons for Verdines and all, or you must have done it yourself. So you do it. You take out the obturator lymph nodes and internal iliac lymph nodes and all, and then you send it for biopsy. They come out to be negative. Then you're saved of doing radical hysterectomy. But the moment they come out to be positive, there was no need of a radical hysterectomy. All right, so it saves a lot of time, it saves a lot of morbidity. So it was increasingly started for vulval carcinoma, but it's now basically more used also for uterine and cervical carcinoma. How, when, we're going to be just discussing it. So basically the aim is to reduce the extent of surgery and the associated complications. You're going and doing the entire chain of obturator lymph nodes and then internal iliac lymph nodes and external iliac lymph nodes and the para-aortic lymph nodes. They're going through the entire chain. But if you just know that the first sentinel lymph nodes are also not involved, you're saved of a lot of steps of surgery, correct? And the associated complications of a systematic inguinofemoral, pelvic, para-aortic lymphadenectomy. So just imagine, for a vulval carcinoma, you chucked off the portion of the carcinoma and then you just mapped it. Nothing came out in the sentinel lymph nodes. You're just very happy with the radical, vulvectomy. That's all you did, right? You didn't go ahead with the inguinofemoral lymph node package. Or maybe a couple of lymph nodes just went in and took it for biopsy. But even they came out to be negative, so you don't have to go further. Are you getting me? If the sentinel lymph node comes out to be positive, that's not such a very good thing. But if it comes out to be negative, it saves a lot of effort. That's my idea of giving you this concept or this entire class today. Of course, you all know sentinel lymph node. You can write down a better answer than probably in my PPT. But the concept has to be very, methodically put inside your brain. That why? So negative sentinel lymph nodes are far more important than the positive sentinel lymph nodes. Because what happens is when you're injecting the dye, which I'll be telling you in a couple of minutes, when you inject the dye, there is a speed with which the dye goes, and there's a concentration with which it goes. So just in case it's not reaching the distant lymph node, that does not mean that they're not positive. It just means that the speed, the absorption has gone so low of injecting the dye, it's not reached there. So that's, not that specific. Now, what did I say? Its usage aims to reduce the extent of surgery. I just told you about that. And it was first reported in 1970s. And basically, you started up with the vulval carcinoma, correct? Now, so we first start with the lymphatic drainage of the pelvic organs. Just give me a while, guys. Just give me a while. Now we start with the lymphatic drainage of the pelvic organs. So the lymphatic drainage of the vulva, primarily to the ipsilateral inguinofemoral lymph nodes, where it can cross the midline if the primary tumor involves the midline. So how many of you know anything about the vulval carcinoma? Has anybody read vulval carcinoma? Do you have any idea? Did you see my class? Did I tell you, regarding this ipsilateral, bilateral lymph nodes? Were you there? How many of you know anything about the vulval carcinoma? It's very essential for me because then I'll go accordingly. So the students in my class, whosoever is there right now, can you please quickly just give me a quick vote as to vulval carcinoma has been read or not read by the students who are there in the class? Do you have any idea? Valcarcinoma and about the lymph nodes? Anything? Anyone? Okay, so I take it as a no. I cannot keep waiting for your answers now. So I take it as a no. So vulval carcinoma, see, when we were students, we wouldn't study much. But finally, what happened was that there was a question on radical vulvectomy procedure and its steps in the final DNB exam. All right, which is what took us, by surprise. And DNB has a habit of, throwing in some kind of questions. But vulval carcinoma, no matter how uncommon it is definitely, it's asked. All right. So specifically, when you're writing down about SLN notes, it's very important. Now, I'll give you a small concept. If the lesion on the vulva is small, less than 4.5 centimeters, and it is on one of the labia, right or left, then the ipsilateral lymph nodes only are removed. So the lesion has to be somewhere around 2 centimeters and less, or a little bit around 2 centimeters, but definitely less than 4.5 centimeters. So only the ipsilateral group of lymph nodes are removed from there. That's the idea. So wide local excision along with ipsilateral lymph node removal. That was the idea. That's what we still do. But the moment the lesion is somewhere in the center, like maybe it's on the clitoris or somewhere, more than 4.5 centimeters, either ways, left labia or right labia, but it's more than 4.5 centimeters, then what do? Is we also remove the other side of the lymph nodes as well. Okay, we use the contralateral lymph nodes as well. That means it's bilateral lymphadenectomy for a tumor of the order of more than 4.5 centimeters. Correct? Now, the lymphatic drainage of the vulva basically goes to the ipsilateral inguinofemoral lymph nodes. Here it is. That's how it goes, right? So if this is the labia we're talking about, it goes here. And if this is the labia we're talking about, it goes here. But if this is the one which you're talking about, it goes both ways. That's why we go for bilateral lymphadenectomy when it is a midline structure. Any midline structure. Keep that in mind. So what we do is superficial lymph nodes are identified medial to the saphenous vein. The most capillate is the deep. You know about this, lymphatic drainage, and I'm not here to tell you about the lymphatic drainage. What I'm trying to tell you is about what's the importance of sentinel lymph node biopsy here. Okay, so this is a little bit about the lymphatic drainage. We are talking about the lymphatic drainage of vulva over here. So this is vulva. Let's just mark it here. Okay, then we talk about the lymphatic drainage of the cervix. Okay, so we just mark that, and then we talk about the uterus, and it's this thing, lymph node drainage. So here it is. So this is what I was talking to you about, the vulva. So it goes into the superficial and deep inguinal lymph nodes, basically ipsilateral. This lesion will drain here, and if suppose there's a lesion here, it will drain here, and then it goes further, deeper and deeper, external iliac, and then para-aortic and stuff.